Well, thank you for being on. We did a podcast a few weeks back, and
Yep.
it was really, even just the one clip I put up, I got had a high number of views. I think it's a topic I know I get a lot of questions about. I was explaining to some of the people on here already that you are a functional podiatrist, so ton of expertise in foot injuries, foot pain, but also I know you are different than a lot of podiatrists, the typical kind of podiatrist, that you'll also think about the rest of the kinetic chain. We even talked all the way up to the thoracic spine in our
Yeah.
podcast before. So you're really unique in that way because most of the podiatrists I interact with, like we talked before, it's very surgery heavy and it's kind of just focused on the foot. So I took some questions from people
Okay.
yesterday, and I wanted to ask you some of these and maybe kind of do, I know we have 30 minutes, just kind of jump through them and see kind of maybe like a rapid fire, like what would you think,
Cool.
about each of these different questions? So does that sound
Yeah.
good?
No, that sounds awesome. And then for everyone who is tuning in is so that they do have that
Yes.
perspective that I always look at the patient from an integrated perspective. The feet are obviously connected to the rest of the body. So I think having that, as you had explained, gives a good insight to the lens at which I look at these different questions that you'll be asking me.
Will you also, just in thinking about that, I'm glad you gave that little intro, like just what is a podiatrist?
So a podiatrist is a foot specialist. So we go to podiatric medical school. So we are a medical doctor. We are all trained to be surgeons. So that is why podiatry typically has a little heavier sway towards surgery. I did surgery for 5 years, moved away from that. And then functional podiatry is really, I mean, I'm trying to carve out that niche and that specialty within podiatry because it is traditionally very foot isolated, supportive shoes, orthotics, or surgery.
Yeah. So the functional podiatry name, that's something you're kind of carving out. That's not like a recognized, it's not like an area that people can go specialize in
Not,
that right now.
not yet.
Yeah, not yet.
Not
Okay.
yet.
Working on it. Working on it. Yeah, I like it. Okay, so Dr. Emily, one of the questions was about heel spurs, pain related to heel spurs. What would you say? How do you treat that? What do you do about a heel spur?
Yeah, and again, I'm going to be doing this rapid fire for because I know you have quite a few questions. So it's actually not the spur that is causing the pain. So that's important for the listeners to understand that the spur is actually like an incidental finding that you will see on X-ray. Oftentimes, I try not even to show them to patients because they will say, "Oh, the spur is sharp. That's what's hurting me." It's the plantar fascia that originates onto the heel that's actually where the symptoms are. So it's really a consideration of plantar fasciitis, fasciosis, or fasciopathy, that we have some sort of micro injury at the origin of the plantar fascia, and that's what we're dealing with.
Got it. Okay, so that's great because there's a ton of plantar fasciitis questions. So say you've got someone who's got plantar fasciitis type symptoms and they also have a bone spur, where would you start with treatment?
So I always differentiate plantar fascial symptoms as acute versus chronic because they will respond to treatment a little bit different. And acute is they've never had this before. Maybe they've had it for 4 weeks, 8 weeks. It's on that acute side, never had it before in their life. That's important. Whereas chronic, it may be waxing and waning. It flares up for a couple weeks. They don't have it for a couple months. It comes back for a couple weeks. And this has happened for years. That's a very classic plantar fascial presentation. Or the third one would be someone who just persists for months with these heel pains. So all of them I address by starting with a putting out the fire. It's a 2-week protocol where I bring support to the foot. I minimize stress as much as possible. We're doing some sort of myofascial release or the body work to the area. And then I incorporate what are called systemic enzymes. And they're doing these 4 things consistently for 2 weeks to try to get control of the situation. Depending on how the patient responds to that 2-week protocol, that guides me into the next step of how I would approach them. So for the listeners, I would say start with that 2-week protocol. I go into it more. I have it on my website and on YouTube and stuff like that. But it's really trying to get control of the situation so that we understand how to navigate where the tissue is in its healing process.
Gotcha. When you move out of that kind of 2 week kind of calming everything down period, when you're thinking about next steps for treating plantar fasciitis, is it based a lot around what you find with their foot, or would you say there's kind of a general protocol that works for most people?
So it depends on how they respond, honestly, to that 2 weeks. So let's say they start with a pain level of an 8 out of
Mhm.
10. after 2 weeks, if they're sitting in a very stereotypical plantar fasciitis that's acute, if you come in as an 8 out of 10 and you do this 2 week protocol consistently 2 weeks, it should drop by 50%, which means you should be a 4 out of 10. If you are, typically I'll carry a patient until they're like a 1 or 2 out of 10. Then I will get into a functional protocol, which would be probably much more similar to what people are familiar with, how you would share exercises, foot strengthening, glute strengthening,
Yes.
all of that will start to incorporate once that patient is like a 1 or 2 out of 10.
Okay, got it.
Yeah.
Okay, and so what about, that person who has the chronic kind of waxing and waning plantar fasciitis? I see, of course we see research about sometimes these things can take a year or more to fully resolve. Sometimes there's a time factor. Sometimes there's the research on specifically loading the plantar fascia through, these calf raises and stretches where the big toe is pre-positioned in dorsiflexion. And then the
Yep.
other one I see more and more is shockwave therapy. What do you think about where do all those things fall in your mind for the chronic plantar fasciitis?
Yeah, so let's say that we have this person again, they're 8 out of 10. They do the protocol and they're like, I am stuck at an 8 out of 10. Okay, my mind is thinking you're on this other side of my flow chart, the chronic. I always get imaging. So I just want to understand what's going on. Do we have degeneration, thickening? Do you have a partial tear of the plantar fascia? Because it could be any of those. Then my treatment would be something regenerative. Do I do shockwave? I love shockwave. I always stack shockwave with regenerative injections.
Like a
And
PRP
regenerative
or something?
injections would be PRP, Wharton's jelly, exosomes. People are doing peptides. Peptides you don't do to the fascia, but there's something that falls under regenerative medicine. And then I carry a patient through this regenerative protocol for 3 months.
Yes.
So it takes 3 months to go through this full tissue healing and remodeling to then start to stress the foot that it can tolerate day-to-day activity and maybe a little bit more like a run or tennis, pickleball, something like that. But oftentimes what I find the number one contributor to persistent symptoms is too early loading.
Got
They
it.
think they're in the clear, they load the foot, and they're at square one again.
I see that out here in California so often with runners, and I'm sure you have a
Yep.
lot of runners like that. They just want to run and they just get back to loading, and things just haven't had enough time to really heal. It's such a common thing I see. So I know you see people in person, but you also have a lot of online clients. Do you, this kind of protocol that you take people through, can people do that by working with you online? Could they find like someone in their area who does regenerative, maybe it can do a PRP injection and they can go get shockwave and they can kind of virtually have you guide them through
Mhm.
that?
Yep, that's absolutely how I do a majority of my patients. So most of my patients are virtual. I go through the recommendations of this protocol. Half of them decide to fly into Arizona and have me do the injection. That's just their own. If they're fully bought in, they're just like, I want you to do the injection. That's great. They don't have to do that though. I will have them do the injections. I will share with them roughly how much volume I would do per area of the injection. And then I will take them through the 3 month protocol and I'll meet with them every 4 weeks. It's actually every 2 weeks we have an update, but every 4 weeks virtually via telemedicine. And then I would guide them through the entire 3 months. So it actually works really well, this model of telemedicine, especially if you have someone on the other side who can do the actual hands-on part of it.
That's
Yeah,
awesome. Okay, I might have somebody in mind to send to
great.
you. Okay, what about can you prevent hammer toes and bunions?
So yes and no. It depends on your foot type because a large contributor to bunions and hammer toes is our foot type. I actually don't blame shoes on this. I feel like I said this on the podcast that we did also, that I don't blame bunions and hammer toes on shoes. And it doesn't mean that certain ones don't contribute to it, sure, but you have this underlying foot type, foot instability, ligament laxity, something that is predisposing you to these bunions and hammer toes. One example that is not flat feet, because I don't want to always be talking about flat feet, is a higher arch, which is called a cavus foot. High arches, cavus feet are predisposed to hammer toes. And this is purely based off of the structural positioning of the foot. You give a mechanical advantage to the extensors, so you get an extensor dominant hammer toe. So this is why I'm a huge fan of toe spacers, releasing the feet, trying to create as much balance as we can despite our foot type.
Hmm. That's something I need to look into because I have that cavus foot. I've always had it like that, kind of a rigid cavus foot, and I noticed that my extensor tendons are always very
Yep.
prominent, and so I really need to experiment more with, it's one of those things that because I haven't had any pain or issues, I just don't think about it much. But the
Yep.
more we talk, I'm like, wow, I really need to check out the toe spacers. They seem like such a great tool.
Such an easy recovery
Yeah,
tool.
and you think for something like that, for someone obviously a bunion, but also maybe something like starting to develop hammer toes, there's something worth trying.
100%. Yeah, bunions, hammer toes, plantar fasciitis, ball of foot pain, neuromas. Those are obviously diagnoses, right, or pain symptoms, but tight shoes, end of the day, right? You just want an easy reset. It's one of the easiest ways because you can walk around in them.
Yeah, yeah, yeah. And I know you said before that one of the most important time periods to use them is when you're actually, if you have an issue, when you're walking. Because a lot of times in walking, especially with bunions and things, your toe can move and you can't control it. And that's where a spacer can really be
Yes.
beneficial.
Bunions and hammer toes are progressive. And what progresses them is every time you take a step. So 5,000, 10,000 times a day, when you're doing just your normal walking around your home or work or commuting, whatever it is, that's actually where you're progressing these bunions and hammer toes. It's not when you're doing yoga or you're weightlifting, which that's the time that people are very conscious of their feet is when they're exercising. It's really the majority of the rest of your day that's where the progression and the stress is happening. And that's where you need to think about using something like a toe spacer in your shoe.
Gotcha. Okay. So just back on the plantar fasciitis, one other question was about hormonal changes like perimenopause, menopause. Can that affect those connective tissues in the foot?
Absolutely, absolutely, 100%. So, hormone changes, decreasing estrogen has an effect on collagen and connective tissue. So, that means, collagen is bone. So, this is where you start to get into bone density as well. But specifically to the foot, the plantar fascia is just going to be a little bit more susceptible to rubber band or elasticity type stress, predisposing you to plantar fasciitis. One other symptom that it's not necessarily related to plantar fasciitis that I see in menopausal or kind of that midlife for women is neuropathy. Hormones can actually cause these menopause associated nerve symptoms. So for any of the listeners, if they're like, oh my gosh, I've been feeling like a burning sensation in the bottom of my feet, that's actually the shifting in hormones.
Hmm. And so would you be a proponent? So would that be, if somebody's wondering if they're having that going on, is that go talk to an endocrinologist and look at getting your hormones tested? What's the path to figuring that out?
I would say yes. It would be more probably a gynecologist is who's following women through that different phase. Maybe a naturopath, maybe an osteopath, right? If they are working more from a holistic perspective, I think that type of doctor would appreciate it a little bit more than a traditional Western gynecologist. It's unfortunate. Or you can actually do your own research and say, if they're not mentioning this to me, then I'm going to take it upon myself to incorporate photobiomodulation or red light therapy to my feet every day as part of, my healthy recovery. I love lymphatic work for women who are going through this midlife. So we might have to take the initiative on our own.
Yeah. And what do you think about collagen supplementation?
Collagen supplementation is great. I love bone broth. I similar in it is the aminos. So I love collagen, but I absolutely love aminos, and we need to make sure that we're providing that as well. And then anything that regulates the inflammatory process, so that we're just regulating inflammation as well.
Got it. Okay, perfect. What about footwear? Are there any kind of general footwear recommendations for things like, say, plantar fasciitis and Achilles tendinopathy? Are there shoe brands that I get asked this a lot too, but are there, yeah, shoe companies that you like?
So, what I would say is if you are in your putting out the fire, that's this 2 week thing that I refer to, and you're trying to get control of the situation, the footwear recommendation is going to be different. It may actually be something that is a little bit more supportive, and that's one of my S's, the 4 steps, the support. That may be a supportive shoe. Maybe it's something like a Hoka that has a little bit more stack. This is transient. We can decide how we move away from this. Or maybe you want to use an over-the-counter arch support like a Power Step or a Naboso form, something that's just bringing a timeout to the tissue. So that's part of it. Once we get out of the plantar fascial symptoms, and let's say you are a nurse who works on their feet for 8 to 10 hours on concrete, you are just defying physiology. You will start to stress your foot at some point. So I actually do like Hoka, and a lot of nurses and people who stand on their feet really do like Hoka. There's pluses and minuses to a shoe like that, but it has its role in an environment like that. Try to get people as natural as possible. So when you're at the gym, then I really like minimal shoes that can flex and twist and really wake up the muscles of your foot so that the foot supports itself, which translates to when you're doing your day-to-day activity.
Mm-hmm. I love that. I love the idea of a tissue timeout.
It is a tissue timeout. Yes. Yep. And no judgment.
Yeah.
No judgment during this 2-week tissue timeout. If you are very anti-arch support, no judgment. We're
Mm-hmm.
just taking a timeout.
Yeah, I love that. That's so great. Okay, and you kind of talked about neuropathy in the lower leg related to hormones. That's great. So that's an aspect people need to consider, especially if they're in that kind of demographic. What about, are there exercises if you have someone who has kind of those neuropathy type symptoms? Are there exercises for that you prescribe?
So I am probably one of the few podiatrists that tells people with neuropathy to get out of their shoes and to stimulate the feet. We do not want to, if you have neuropathy, you don't want to be living in a bubble because one, who wants to live in a bubble, right? You have to live life also. So how do we find a controlled environment to get that sensory stimulation to your feet as well? We need to get our shoes off to challenge the neuroplasticity of the peripheral nervous system. Do it smart, clean the feet, look at them before and after, right? I love vibration, so whole body vibration platforms. I have one in my office over there. Obviously, any of the Naboso products where you're bringing in texture, minimal shoes, earthing. So you're trying to still think about how do I keep my peripheral nerves healthy? And then how do I strengthen the small muscles, the intrinsic muscles in the bottom of the foot, which play an important role in balance, which is, of course, important for anyone who has neuropathy.
Mm-hmm.
So, very much there has to be focus towards sensory stimulation and motor strengthening of a neuropathic foot.
Okay, awesome. I love that. Yeah, I feel like that's one of the areas I'm often talking about is kind of helping people understand the difference between intrinsic and extrinsic
Yep.
muscles in the lower leg and the foot and how important, because a lot of us don't, a lot of people just don't know much about the intrinsic muscles and how important they are. So it's amazing how many muscles are in the bottom of your foot. It's
I know
pretty crazy.
that's why I keep telling you to bring in appreciation or a fascination of like, wow, there are 26 muscles, right? Like that is just fascinating.
It's
And
amazing.
they contract isometrically. So those muscles are stiffening muscles and
Mm.
they create the stability of the foot during dynamic movement, which is why I love short foot exercise, which is when you push your toes into the ground. That exercise or that action activates those 26 muscles to stiffen, which is how you use them when you move dynamically.
Mm. So, those people you were talking about, say it's a nurse who stands all day, and eventually, in most cases, they're going to hit a point after a certain amount of time where that can lead to problems. Do you think that that has to do with those intrinsic muscles becoming fatigued?
I think that it is a combination of the foot to core postural muscles getting fatigued, meaning that we just we forget about it, right? We get a little lazy in gravity. And I spend a lot of my time connecting the feet to the pelvic floor because that's how you resist gravity. That's your posture. And half the people are going to forget the pelvic floor, and then the other half are going to forget about their feet. So we need to focus on both. But a great exercise for those who are familiar with activating their pelvic floor is if you stand with your feet shoulder width apart and you're kind of nice and relaxed, and then you lift the pelvic floor and you're really good at like mind body connection, you should feel that you feel lighter in your feet as soon as you lift your pelvic floor. So it's a really great demonstration of people who get like low back pain or people who get diffuse foot pain or foot fatigue. They're just like the whole foot, like just the whole bottom of my foot hurts. That's telling me that they're actually passive in gravity. They're like subjecting themselves to this downward pressure, and they need to say hello to their fascial tissue and put some tone in it so that we can actually resist into gravity. And to me, that's how I start to address that diffuse foot pain or diffuse foot fatigue.
I love that. Yeah, you can imagine anytime you're standing for long periods, we all know we've had this happen where you kind of forget or you're not your neuromuscular system's kind of gone to sleep and you're just letting gravity kind of all the force is going into your joints and ligaments and you'll see people hyperextend their knees, their foot or their arches collapsing, their pelvic floors off and just that reminder to kind of reactivate and get a little tone back and everything can be a
Yep.
huge part of just changing the stress, taking some stress off, and kind of making you feel lighter.
Yep.
So,
100%. Because especially if you're working, you're ergonomically thinking about something else also.
totally, yeah. Okay, what about someone asked about pain and weakness in the peroneus brevis and their peroneal muscles?
Okay, so for those that don't know where the perineals are, they're on the outside of your lower legs. So kind of sometimes people say your outside calf, but those are your perineals, and these are lateral outside ankle stabilizers. The brevis inserts onto the fifth, which is the bump on the side of the foot. That oftentimes I will find that people will get irritation in their perineals based off of their foot type. So in those that have a flat foot, overpronated, they're kind of collapsing towards the inside, you'll actually see a lot of transfer stress into the perineals. It could be a lot of single leg movements. Maybe they're doing trail running, so there's a lot of wobble of the foot, and they're starting to stress the perineals. Sometimes depending on shoes that you're wearing. So I would be curious of who asked this, of kind of their foot type, where it's presenting, why it's presenting. Perineal tears are actually common in people who have a overpronated foot. And what happens when your foot overpronates and collapse in is your fibula, which is where the perineals sit, rotates ever so slightly, and then you actually rub your perineals against the bone and you can tear it easily. So tears, split tears in the perineals are actually quite common.
Yes, I had a friend who had a split tear, and I did not know that about the overpronation
Mhm.
and that kind of like that friction that it creates on the tendon. I didn't realize that.
Yep. That contributes to snapping perineals as well. So if anyone has ever heard of that, I always look at foot type and I don't go straight towards, oh, you have snapping perineals. That means you tore the retinaculum. That's right. Or you have a shallow groove, which are like textbook reasons. Oftentimes I find that it's that overpronation and you just learn to control that rear foot a little bit better. Maybe they use an orthotic, right? But it'll bring control and better alignment to the way the perineals sit and they'll stop snapping.
Yeah, I have a snapping peroneal tendon on one side. It's the
Mm.
side that it's only one time I've had a bad inversion ankle sprain. I think I tore the retinaculum maybe, and so sometimes when I squat and it's a little bit when I'm squatting and I'm kind of in between pronation and supination, just that little bit of movement, the tendon will
Yep.
snap. So
Yep. Almost like cox's sultans, like a snapping hip.
yes.
And so I have that on my right side. I have a torn labrum and long story there. But if I do from extension, flexion to extension, that's what causes the snap in the internal of the groin. If I just slightly position my pelvis, really connect and activate my pelvic floor, my snapping hip goes away. So it's really fascinating, subtle little tweaks or activation of stabilizers in our skeletal system will make some of those snapping tendons just kind of slide right where they
It's
need to.
so true. That one with my perineals, if I just lock in and think about stabilizing my foot and arch and ankle, it stops.
Mhm.
It's just
Yeah,
when I'm not thinking about it, I'm thinking about the squat and I notice, oh, my ankle's it's doing that medial lateral kind of movement. It's kind of going
yeah,
like that and then it ding, ding, ding. So
fascinating.
Dr. Emily, this was amazing. We jumped through all the questions I had. You've mentioned, I know you have a bunch of different tools out there that people could go look at. Like I know the toe spacers, like different sensory
Yep,
tools for the feet. Where can people
neural.
where can people find all that? Like where can they find more about what you do and the tools you have?
Yeah. So my podiatry practice, now that I'm on this Instagram, is the same URL. So it's the Functional Foot Doc, or it's my name. So that's where I see patients virtually, in person. My focus is functional podiatry and regenerative podiatry. So just in case if they're curious on that. For Naboso, Naboso is Naboso. So we have our ball, we have release tools, we have insult, lots of great fun stuff. All of it is sensory based. As a functional podiatrist, my approach is very much based around sensory stimulation. I versus biomechanics. I'm very into accessing the nervous system in the brain to control movement. That's my step one. And then, of course, appreciating biomechanics. So Naboso.com. And then our Instagram is Naboso_technology. And I know holiday is like right around the corner, so we have awesome sales. So check that out. Stock up for Christmas.
That's amazing. Well, it's all about the nervous system, so you're speaking my language.
Yes.
So thank you for taking the time to do this. It is super helpful. I love having people who are specialists in other areas because I can talk a little bit about some of these foot things, but nowhere to the degree of nuance that you can get into all this stuff. So I appreciate the
Of
time, and
course.
thanks again for doing this.
Yes, I love chatting with you, Dr. Tom. So we'll do it
Uh,
again soon.
Sounds good. All right. See you, everyone.
Bye.
See you, Dr. Bye.